morning. Are you good to go or do you want me to wait?
Sir, yeah, just a wait for 1 minute, sir.
Okay.
Before we start, it's Dr. Anand Nagar, sir, from AIMS Rishikesh, and me and Dr. VK Kapoor are working together, and we started this online education platform, Jaipur Surgical Tutorial, around 4 years back. So every Saturday in the morning, 9 to 10, we have a class. It may be like guest lecture or a faculty lecture or a clinical case capsules or a operative surgery. We'll discuss on Saturday, sir. So we are doing every Saturday. So till now we have done approximately more than 200 classes, and these
Wow.
all classes are uploaded by Dr. Avinash Tak and his team on the Gastro University. We have a YouTube link for this for the classes. So we are doing regularly every Saturday. We are doing these classes, sir. So now I request Dr. Avinash sir to introduce our speaker and invite him for the lecture. Avinash sir.
Thank you, Dr. Anand. Uh, Good morning to all the participants, our esteemed speaker for today's guest lecture, Professor Somaya Aruri. I welcome Dr. Somaya Aruri on this platform of the Gastro University to deliver a very important talk for the GI surgeons, especially practicing for the liver surgery, the role of intraoperative ultrasound in the liver surgery. Professor Somaya Aruri is a senior consultant HPB and renal transplant surgeon at most prestigious center in the UK, that is the University Hospitals, Plymouth, NHS Trust, UK. So now I invite Professor Somaya Aruri. Stage is yours. Please enlighten us about the role of intraoperative ultrasound in liver surgery. Over to you, sir.
Thank you, both of
Just
you.
1 minute, sir.
Yeah.
I want to just introduce one more moderator with us, Dr. Hiram Chaudhary. He is a assistant professor in intervention radiology at Mahatma Gandhi Hospital, Jaipur. Dr. Hira, just say hello.
Good morning, everyone. Nice to see you all, guys. And yeah,
So,
we can
Dr.
good to
Hira
go.
is our intervention radiologist at Mahatma Gandhi, and he is also doing our intraoperative ultrasound. He was doing liver transplant, sir. So now,
Oh,
Dr. Samaya Arori is over to you, sir. Thank you.
no, thank you, Anand. Thanks for the invitation. As I said, it's a bit early in the morning in the UK. Hopefully, I should be awake. I've been asked to speak about intraoperative ultrasound scan in HPB and liver transplant surgery. I hope I have enough time to give you a decent bit of information, but anytime during the talk, please interrupt if you want to. If not, I can take the questions at the end. Now, before I talk about intraoperative ultrasound scan, it's very important to. Oh, wait a second. Important to mention that I have no conflict of interest and I'm not a radiologist. So if you have any, difficult questions related to the radiology, please do refer to our intervention colleague who is going to moderate the session. Now, why intraoperative ultrasound scan? I think before I answer that question, it's important to know what do we need to know if you are a practicing liver surgeon or you're thinking of becoming a liver surgeon, because if you think about either colorectal surgery or esophagogastric surgery, most of the times the information you need to know is straightforward and it's easy to decide in terms of whether to go for surgery or go for chemotherapy before surgery or after surgery. So it's pretty straightforward discussion in the meeting, and it's not that complicated. But when it comes to the liver, the information what you need is a lot more than what information you would need for a OG or a colorectal or a urology surgery. So what information we need to know and why do we need to know? Because the reason for this is liver is a complex organ. So the first thing we need to know when we sit in the MDT, we want to know whether liver parenchyma is abnormal or normal. And you know the reason for this, because if you have cirrhotic, for example, the pathology you're looking in the liver may be different to compared to non-cirrhotic livers. And also you want to know whether there is any signs of portal hypertension or not, because that has implications in terms of whether you go for resection surgery or transplantation or some other modality of treatment. If you have a fatty liver or chemo liver and also the cirrhotic liver, the amount of liver you can resect is also going to be affected because you won't be able to take out up to 80% of the normal liver if it's a liver is normal. So the first thing, as I said, in the sitting in the MDT, I'll look at is the liver parenchyma. What is it? Is it normal or abnormal? If it is abnormal, is it chemo liver, post chemo liver, cirrhotic, fibrotic, or fatty or normal liver? Then I want to look at the anatomy of the liver itself and the anatomical variations. Liver is the only organ which has almost up to 30% of anatomical variations in terms of arterial, portal venous, and biliary anomalies. These are very important in terms of planning the resection, type of resection, and also whether the tumor is resectable or not itself. Plus, you need to understand the intrahepatic anatomy, even though there are no variations, because especially when you're planning for a minimal invasive surgery, it's all about planning. Because if you know where you're going to encounter the middle hepatic vein or right hepatic vein, or if there are two or three right hepatic veins, then you can preempt it and prevent the complication, which is the bleeding, which is the most dreaded complication of liver surgery. So understanding of the intrahepatic anatomy is really important compared to, let's say, for example, if you're planning to do a right hemicolectomy, you know where the tumor is, you really don't need to know much about what's happening inside the right colon other than the tumor. Then you want to know more information about the tumor because planning the type of resection is crucial once you know where the tumors are. So the characterization, and it's important to know whether they're neuroendocrine tumors or colorectal cancer, HCC. For example, if it's a neuroendocrine tumor, if you're planning only to debulk it, so R0, R1, R2 doesn't really matter because the aim is to debulk it rather than curative option. But if it's a colorectal metastasis away from the blood vessels, you should aim for R0 resection. Same with the HCC as well. If it's a hemangioma, you don't want to take them out. So it's important to identify what is the nature of these tumors. Then you want to know where they are, how there, which segments are involved, how many segments are involved. Then you can decide whether you want to do a parenchymal preserving surgery or whether you want to do a major liver resection. You also want to know the relationship to the inflow and outflow, because if even though the tumor may be small, but if it is at the confluence of the three hepatic veins, then you're not going to probably resect it. Or you may resect it, but you will accept R1 vascular resection. So it's important again to know the relationship to the inflow and outflow, relationship with the gallbladder. Why this is important? If you're planning for an ablation, the tumor is close to the gallbladder, then almost certainly you could end up making a hole in the back wall of the gallbladder. Therefore, you may want to take out the gallbladder as well at the same time. And then obviously, is it operable or not? We've already talked about it. It depends on the location of the tumor, how big is the tumor, and also how much liver you're going to leave behind. Then the surgical approach, because there are so many approaches, you have laparoscopic approach, a hybrid approach, robotic approach, and open approach. So you need to again know exactly whether any of these approaches are feasible or you want to go for a straight and open operation. So it all depends on the size of the tumor, location, and also your skill. Now, other important thing is if you're planning for major liver resection, you need to know what is the blood flow to the remnant liver because there are so many variations. For example, if you think about one of the anatomical variations of the portal vein, where the right anterior is coming from the left, and if you're planning to do a left hepatectomy, you've got to be very careful not to damage the right anterior sectoral vein, and vice versa. So it's important before you ligate something, you make sure that your blood flow to the remnant liver is absolutely fine. I have had problems once where planning to do a laparoscopic right hepatectomy and the staple moved, which we didn't realize during the ligation of the portal vein with the stapler, and then we ended up taking the patient back to theater. So it's important to make sure that the flow is to the remnant liver is absolutely fine before you close the patient. And then we talked about the future liver remnant, and not just the size, but we also want to know about the function. So I think the most important term, I think it's the functional liver remnant rather than the future liver remnant. But there are not many tests that will give you the amount of remnant liver function. So where do we get this information? So just to recap, these are all the information what we need for planning liver surgery compared to any other surgery in the abdomen. So where do we get all this information? Because unless you have all this information, it's very difficult to plan the type of surgery, the approach to the liver surgery, and also about the future liver remnant. So all this information you get it from three sources. One is from your anatomical knowledge from the medical school, and also once you become a surgical trainee, obviously you will be taught about the anatomy of the liver much more than what you would learn during your medical school. Then the other important piece of information which you get it is from your preoperative blood tests and also imaging. And sometimes you do go for biopsy, especially if you're in Spain. If you're thinking of HCC, almost every patient with suspected HCC, they get a biopsy done. But the most important piece of information you get it is from the cross-sectional imaging, that is CT, MRI, PET-CT, and sometimes few other important other investigations. And then the third is the intraoperative imaging. So what about the two most commonly performed investigations, that is CT and MRI? So what are the advantages of CT? It's very easy, quick to get it. You can be interpreted by surgeons, just not the radiologists. So I do not operate on any patient unless I look at the CT scan myself, because the angle I will be looking at the CT is different from compared to the radiologist. Then I can also do the reconstruction, and volumetry option is there, especially if you're planning for major liver resection. And also you can find out about the extrahepatic disease. So you get a lot of information from the CT. But what are the disadvantages? Even though it is a must, but there are some kind of limitations. I shouldn't say disadvantages. So what are the limitations? The limitations are, one is exposure to radiation. So if you want to repeat it several times, you need to think twice and thrice before you ask for it. It's not as sensitive as the MRI scan when it comes to the small tumors, and also when you want to assess the background status of the liver. It can miss some of the tumors, and some it is very difficult to characterize even with the CT scan. But the most important thing is about the CT is it's not real time. So if I do a CT today and if I'm going to operate tomorrow, it's still there is a 24-hour delay. And most of the times in reality, you have a long gap, at least a few weeks between the CT and operating, especially in NHS. It is also not going to help you with the identification of the margins, because, as I said, it's important to find out whether you can do R0, R1, R2 resection. If you want to mark the resection margin, CT is not going to be of any help. And I've also mentioned about the sensitivity when it assessing the parenchyma of the liver. It's not it's not as good as MRI scan. So the next best, more common modality you use, the MRI scan, is much more sensitive and specific compared to the CT scan. It will tell you about the background status of the liver as well, but it's still got its limitations. So it's costly, and there is a toxicity associated with the contrast which we use in MRI scan. Not every patient can have MRI, especially if you have a cardiac device which is not compatible with MRI scan, or if you are claustrophobic, then you're probably not going to have MRI scan. Now, other important limitation for me is that I can't interpret the MRI scan unless I spend a lot of time reading the MRI scan, understanding what is T1, T2 weighted images or diffusion weighted images. It's difficult for me to interpret the MRI scan. So, unfortunately, it's not surgeons friendly. Other issue is, like the CT, is not real time, and it also cannot help with the marking of the margins. Even though it is sensitive, more sensitive than the CT, still got its limitations in terms of picking up the smaller lesions. So these are all the limitations with the cross-sectional imaging. Obviously, these two tests are a must, and they will give you most of the information what you need, but still not the every single piece of information what you need for planning for liver surgery. What about preoperative imaging? Sorry, we just covered about that. What about the intraoperative examination? Because a lot of surgeons said to me that, Prof, why do we need to do any other tests other than preoperative CT and MRI and examination of the liver? Now, the literature suggests, and also from my own experience, you can see that in almost 20 to 40% of the patients, the tumors are not visible or palpable. So either they're too deep or they're too small to either visualize or palpate it. Now, my hands are not magic, so I can't assess the flow to the remnant liver. I can't assess the relationship of the tumor to the inflow and outflow. I don't know how many are there, especially if you have multiple colorectal metastases and you had chemotherapy. Some of them would disappear, some of them are still there, but they're too small. So you can't see it or feel them. I won't be able to tell you about the anatomical variations. And also, there is a phenomenon called tumor bug phenomenon. And like the tip of the iceberg, I'll show you a image where you won't be able to see how deep is the tumor. You also won't be able to identify the margins accurately. Yes, you can guess it and mark it where you think it is, but often you get it wrong. If you're planning for laparoscopic or robotic, there's no tactile feedback, so you have to rely on something else. And in cirrhotic liver, there are so many nodules, and you would be thinking where the tumor is. I did one yesterday, and without ultrasound scan, there is no way we would be doing a liver resection in a grossly cirrhotic liver, and the tumor is in the middle of the liver, and you can't see it and you can't feel it. It's a laparoscopic operation. And also, there is a lot of subjectivity, a lot of guesswork. And I always worry when I'm guessing where the tumor is and where the margins are. And I don't want to guess it. I want to make it absolutely accurate so that I give the best outcome to the patient. So look at this one. I mean, this is the tumor, what you see. That is the only tumor you can see it, but actually the tumor is much, much bigger inside, and there are actually more than one tumor. So I'll show you a ultrasound video of this patient later on. And look at this one. I mean, that is a cirrhotic liver. How on earth can you tell me where the tumor is? Even though you know where the tumor is on the CT or MRI scan. But when it comes to the intraoperative imaging, it's absolutely guesswork. And try and dig out a tumor from this cirrhotic liver is absolute nightmare, and it's impossible. So you have to rely on something else. So, because of all those inaccuracies, limitations of the cross-sectional imaging, you have to rely on something which is real time, which will can give you all the information, plus more than what you can get it from the CT and MRI scan. And that's where the intraoperative ultrasound comes into place. So what is an ultrasound scan? So I'm going to touch about a few basics about the ultrasound scan. And I always say this when I teach anybody that most of the time you get an answer from the name itself, ultrasound. So it's a sound wave. Why is it ultrasound? Because it is beyond the human hearing capability. And the frequency of the ultrasound is more than 20,000 hertz. So the frequency is measured in hertz. It's very important for you to remember this, because when we talk about the frequency, what we use for the intraoperative ultrasound scan, you need to know what the hertz are. So that's a unit, and the frequency is the number of waves per second. Now, one important thing you must remember for ultrasound scan, you need a medium. So, and the speed of the ultrasound will depend on what medium you're using. So, if it's a solid, the medium, the speed is much higher than liquids, and then very, very slow in air. That's why when you see the ultrasonologist, they always use the gel when you're trying to do the percutaneous ultrasound scan. But for intraoperative ultrasound scan, it's slightly different. So that's the wave. You can see that's the wave per second. We're going to go a little bit more into. So in terms of the properties, now I'm just going to mention this. It's important for you to just remember. So the properties are, one is the frequency and the penetration. There's something called acoustic impedance, which is basically the impedance provided by the tissue of interest, or in other words, resistance, how much resistance you get. Ultrasound is nothing but energy, by the way. Okay, it's an energy which is trying to transfer from one place to another place in the form of a wave. The other features we need to think about is the resolution, attenuation, reflection, and refraction. I'm not going to go into all these details, but the most important one you need to remember is this. So there is a direct relationship between the frequency and the resolution. So if you want the best resolution, you want the high frequency. And usually the frequency we use for the ultrasound scan is between 7 to 14 megahertz, not kilohertz, megahertz. 17 to 14, that's what we use for the intraoperative ultrasound scan. So if you want the best resolution, you increase the frequency. But unfortunately, if you increase the frequency, the penetration is much, much slower. So you won't be able to get the depth. So the relationship between the frequency and the depth is inverse, but the relationship between the the resolution and the frequency is directly proportional. I go for the resolution rather than penetration, because when I place the probe directly on the organ of interest, I'm not really worried about the penetration, because I can change the direction and the place where I place it. But when you're doing a percutaneous ultrasound scan, you go for a lower frequency because you want the penetration. So that's important for you to remember. Now, I just want to talk about what is the difference between intraoperative ultrasound scan and ultrasound scan done by the radiologist with a percutaneous ultrasound scan or a transabdominal ultrasound scan. So we do not get the radiologist into theater. We do our ultrasound scan ourselves because we have been using it for so long, nearly. So we started using in 2005. I've been a consultant now 14 years. So I do myself, and sometimes I do go and help my colleagues as well. But all of us are very good at doing intraoperative ultrasound scan. The only time we call ultrasound radiologists is when we want to do the ablation. So they come and place the probe under our intraoperative ultrasound scan guidance. So compared to the percutaneous ultrasound scan, it is much more sensitive. You can place on the directly on the organ of interest, whether that's the liver or bile duct or pancreas or any other organ you can think of. Yesterday I did a pheochromocytoma, and the tumor was right high up under the pancreas. Normally you see the adrenal gland just above the upper pole of the kidney, but this time it was much higher and under the pancreas and close to the splenic hilum, retrosplenic. And I place ultrasound scan, I know exactly where it is, and then you will go and dissect it out. So it saves you a lot of time. And the other thing is you don't need any gel, because moisture on the top of the organ will be acting like the medium. You can use it sterile or unsterile. We use unsterile, but we use a condom so that it is obviously sterile, but we don't have to sterilize the probe, and you don't need to have that many probes. And as I said, the frequency is much higher because you want the resolution. You can repeat it as many times as possible. You can't do any damage. It's very sensitive and specific. The only issue with intraoperative ultrasound, it's not an issue. The limitation is that it is subjective. In other words, you need to know what you are talking about it. So there is a bit of a subjectivity, and that's why there is a bit of a learning curve. So if you learn from a master, then your learning curve will be much shorter, then you won't need the radiologist. So that is the limitation of intraoperable. Of course, the costs as well, but you recuperate the money once you do it so many times, and it will save you a lot of other complications as well, and R1 resections when you're not planning to do them. I've talked about the properties. The other important thing to remember is the color signal. So when you press the color button on the ultrasound scan, blue doesn't mean it's a vein, red doesn't mean it's an artery. It's all to do with the direction of the blood flow towards the probe or away from the probe. So if the flow is away from the probe, even if it is an artery, it will look blue. If it is towards the probe, it will look red, but it doesn't matter whether it's an artery or the vein. So just that is important for you to remember. Now, most of the big blood vessels inside the body will have both blue and red, because there will be some flow towards the probe, some will be away. I use the word yin-yang appearance, so it can be blue and red together. What about the terminology? This can be confusing, but it's very important and easy to remember, is that black means anechoic. That means there are no ultrasound waves that are coming back to the machine. Everything is going through. So the fluid will be anechoic. So if you look at that, that's anechoic. It's black, anechoic. Then the next extreme is the white, that is hyperechoic. Anything bright is hyperechoic, or we call echo bright. So that's hyperechoic. And then the third important thing to remember is anything in between black and white is gray, and that's hypo. So that's hypoechoic. So that's anechoic, no ultrasound waves coming back. That is usually from the fluid. If it is bright, that is hyperechoic. That's usually any tissue containing fluids or muscle, something like that, which has got a lot of fluid or fat. But anything in between, any other tissue will be hypoechoic. So that is hypoechoic. Then the last term we use, isoechoic, that is only when you compare one with each other. So let's say that is isoechoic compared to this. But I can't say that is isoechoic if I'm not referring to this as well. So isoechoic is the term when we use when you compare one each other. Okay, I hope that's clear. So anechoic is black. So any fluid containing tissue will be anechoic. Isoechoic is when you compare two things. Hypo is gray, hyper is echo bright. That is hyperechoic. And also remember, solid, even though the medium speed is very high, but unfortunately density is also high. So the acoustic impedance I mentioned very briefly is basically a multiplication of the speed and the density. Higher the acoustic impedance, that means most of the ultrasound waves gets reflected. And also if you have a very low acoustic impedance like air, that will also unfortunately will not let the ultrasound waves to get through. So that will be kind of bright. I just want to mention two artifacts. One is the posterior acoustic shadow. Here you can see that's a stone because it will not let the ultrasound waves to get through. So there'll be a shadow behind it. That is the typical characteristic of ultrasound of a stone in the bile duct. That's what we use to find out if there's a stone in the bile duct or not. The other one is posterior acoustic enhancement, because when the ultrasound goes through the fluid and the solid, they enhance, the energy gets enhanced, and then you see the acoustic enhancement. That's a typical of any fluid containing cyst or gallbladder or the bladder, urinary bladder. So if you see that, that is mostly a fluid containing structure, what you're looking at it. So it's useful to identify the pathology. Now, other thing, important thing we need to remember when you're doing the ultrasound scan, if you ask a radiologist, with no disrespect to them, they don't have any landmarks. They just go to the hilum, they know how a portal vein looks like, and that's it. And then they carry on the ultrasound scan. But so there's no landmark. So this is the landmark technique I developed and we published as well. It's called Aruri ligamentum venosum technique. That's what I teach everywhere. So ligamentum venosum is the remnant of the ductus venosus, which connects the portal vein to the IVC, and you can see that as a very thick echobright structure. So that is the ligamentum venosum. It is always there. So if you trace one end, that will take you to the left portal vein, vertical and horizontal portion, and the other end will take you to the junction of the left and the middle hepatic vein, where the left and the middle join the IVC. So it's always there. So if you get lost, you go back to the ligamentum venosum and you start your technique. I'll go through that in a minute. And the other important thing for you to remember is how to identify the portal vein, hepatic artery, and the hepatic vein. So very brief description. Now, all these three structures, whether it's a hepatic vein, hepatic artery, or the portal vein, they're all anechoic, black tubular structures. But when it comes to the portal vein, you have the echobright Glisonian capsule. But unfortunately, hepatic veins can also have them very close to the diaphragm, and also inflamed bile ducts can look like that. So important thing is to put the color, and if you press the color button, you see the yin-yang appearance. And also the branching pattern is different from the hepatic artery, hepatic vein. So these three features will help you. So that's the anechoic black tubular structure. It's got an echobright thick layer, and it will have a yin-yang appearance. But the most important feature is the Doppler wave pattern. So the wave pattern is this. It's positive or negative and flat. Basically, it's monophasic with hardly any changes to the respiration. So that's one of the video of a patient. That's the portal vein. So that's got a yin-yang appearance. And then you press the pulse wave pattern and you see that. If you see that, either positive or negative, depending upon the direction, but it is flat. It's monophasic, so there's not much of a change with the respiration. That's portal vein. What about the hepatic vein? Compared to the portal vein, hepatic vein has got this, what we call a periodic wave pattern. So you got one positive wave and you have pretty much three negative waves, and that is the typical of hepatic vein. Hepatic vein will follow the right atrium. So you have A wave, atrial contraction, S, V, and D is related to the ventricular systole, and atrial overfilling and tricuspid valve opening. And that's the typically what's the pattern looks like compared to the portal vein, which is positive or negative and flat. Hepatic vein is almost like what we call a periodic, not triphasic, periodic wave pattern. If you know how a normal wave pattern looks like, then you can tell whether it's abnormal or not. So that's another one of a hepatic vein. So that is taken at the confluence of all three hepatic veins. You can see the yin-yang appearance, both blue and red, because they're big tubular structures. And you can see the positive and negative waves. Now look at this one, the left right-hand one. This is a patient with a massive tumor here. The middle hepatic vein is compressed, and you can see there is no negative wave. Everything is positive. So I know straight away that it is obstructed. And there's no point in trying to preserve the middle hepatic vein. It has to go. So you can tell whether it's normal or not abnormal based on your knowledge of how a normal hepatic venous pattern and portal vein pattern. What about hepatic artery? So hepatic artery is also black tubular structure. And obviously the branching pattern will help you to tell whether it's an artery or not. It can also have a little bit of hyperechoic layer because of the Glisonian capsule. But what is most important is the triphasic wave pattern. Look at this one. So that's the typical hepatic artery. So that's normal. So now you've seen the portal vein, which is positive or negative and flat. Hepatic vein is a periodic wave pattern. You have seen one positive wave and three negative waves, whereas the hepatic artery is all positive. It can be negative as well, depending upon where you place the probe, but it is always triphasic. Okay. So that's the typical pattern. Now you look at this one in a patient with cirrhotic hepatic arteries, significantly kind of narrowed because of the portal hypertension, you have the portal vein narrowing as well. And you can see the wave pattern is much more shorter, much high peaked. So that's a typical the cirrhotic liver with the hepatic artery Doppler wave pattern. So in terms of the technique, I talk about two techniques. One is the contact scanning, where you place the ultrasound directly on the organ of interest. Sorry, I hope I'm not doing too bad with the time. So one, you place directly on the organ of interest, but sometimes you may have to do what we call a probe stand-up scanning technique. So where, let's say, for example, if I have a cirrhotic liver, very nodular liver, then you want to place a saline bag, either a glove or fill the abdominal cavity with saline, and you place the probe on the top of the saline so that you can see what is underneath the saline. And also liver transplantation, and I've been asked this question quite regularly that, Prof, it's very difficult to identify the hepatic artery after the anastomosis. The reason for that is if you place the ultrasound directly on the hepatic arterial anastomosis, you won't be able to see anything because there is nothing, there's no medium in between the probe and the hepatic artery. So you must fill it with saline, or you place a glove with saline, and then you place the probe on top of that. And also segment 7, it's difficult to access. And also, if you have a small superficial tumor, so look at this one. There's a small cyst here on the top of the liver. If you place the probe directly on it, you will miss it. So make sure you have what we call a probe stand-up scanning technique, where you fill a saline and you place the probe directly on top of the saline, then you can see it. So those three, other than those three areas, so where you have a cirrhotic liver or a small superficial tumors, and also segment 7 difficult to access, or if you have a tube which you want to assess the patency, in those scenarios you do probe stand-up scan technique. Otherwise, it will be contact scanning. So what I would suggest is that don't mobilize the liver if you want to learn the intraoperative ultrasound scan first, because once you mobilize the liver, air gets in or CO2 gets in, that will interfere with your vision. So make sure that you mobilize only tiny little bit, and then you do the scan with the view to scan the entire liver to identify the normal anatomy. Then you mobilize the liver, you repeat it this time in terms of deciding what surgery you want to plan. And as I said, I'll go to the technique I published just for your information. So that is ligamentum venosum. It's one of my patient. So that is ligamentum venosum. Basically, if you open the lesser omentum and you follow the lesser omentum into the liver, that is between the caudate lobe and the left lateral sector. And one end is the caval end, and the other end is the portal end. So these are the steps I talk about. As I said, it's called ALV technique. So this is basically what I teach. I don't obviously follow that because I don't need to follow this. But if you're a beginner, this is what I would suggest. So you place the probe between the segment 2, 3, and 4B, and you identify the falciform ligament first. And you trace the portal end that will take you to the junction of the left vertical and horizontal portion of the left portal vein. Then you identify all the branches of the left portal veins, that is segment 2, 3, 4A, and 4B. Then you come down to the horizontal portion of the left portal vein. The only branch that comes from this is the caudate. You may not be able to pick it up, but if you're good at it, you will be able to pick it up. And then you go to the right, and then you identify the right anterior septal vein until it divides and trace the segment 5 and 8 branch. Then you go back to the right posterior septal vein and trace its segment 6 and segment 7 branch. Then you go back to the ligamentum venosum. Now this time you identify the hepatic venous end at the junction of the left and the middle hepatic vein. Then you trace the left hepatic vein to its origin, then the middle hepatic vein to its origin, and then the right hepatic vein to its origin, and all the branches. At some point, you must trace the Cantley's line, and also you must identify the right hepatic vein between the right anterior and sectoral vein, right anterior and posterior sectoral vein, and then the left between segment 2 and 3 veins. So that is a technique I teach. So just an ultrasound scan. So that's where I place the probe. Same with the lap or robotic. And that's the ligamentum venosum. It's very easy to identify. That's the caudate lobe. That's the IVC. And that's the portal vein, vertical portion of the left portal vein. Just to go back, again, that's the hepatic vein. Those are the hepatic veins. That's the left, the middle, and the right. So you can see one end is the portal end. All right. That's the portal end of the ligamentum venosum. And you just literally tilt the ultrasound probe up and down without moving up and down. You just tilt it. And that can take you to the the caval end of the ligamentum venosum. And then you trace obviously the portal vein or the hepatic vein. It's up to you, but I would go with the hepatic vein first and then the portal vein. Portal vein first, then the hepatic veins. Okay, so that is the technique I teach. What about the laparoscopic technique? Is exactly the same. The only difference is that you follow the curvature of the liver. You don't press it too hard. If you press it too hard, the structures inside the liver will disappear. Make sure that there are no air bubbles. If you're using the condom, we use the condom because we don't have that many probes. We just have two laparoscopic probe and two open probes. So we don't want to damage them. We always use a sterile condom. And in terms of the port position, depending upon what surgery you're planning to do, so you need to decide if it's a right hepatectomy or left hepatectomy. You usually go with the mid-clavicular port for the ultrasound scan. If it's a distal pancreatectomy, it's a left mid-clavicular port. If it is a laparoscopic CBD exploration, it's usually the epigastric port. So this is a technique which I use. The key is to follow the curvature of the liver, and that's a cirrhotic liver, so I'm putting a bit more pressure, but you usually follow, and you move from a patient's right to the left, okay? And it can be a little bit difficult in the beginning. Once you kind of start doing a few times, then it'll be easier. What about the robotic? Is exactly the same. I use the assistant port to put the probe inside, and then you grab it with either the left or the right arm, and then the rest is exactly the same. Don't press too hard, just follow the curvature. And obviously, this has to be sterile because there is no option of the condom, and you don't need the condom because you can use the metal clip at the top. You look at the video. Here is one of the patient I did. So that's ultrasound probe. And it's obviously sterile and it is metal. There is a metal clip at the top, and you use one of your graspers to hold it, and then you follow the curvature of the liver, and you actually access will be much easier than laparoscopic because the probe is small and the range of movements are much wider. So this is one of the right hepatectomy I was planning to do. I've already taken the inflow to the right. You can see the difference in the color. Okay. So now I'm just going to go through. Am I doing okay time-wise, guys? Yeah?
Yes, sir.
Yeah. So I'm just going to go through a few examples where the ultrasound scan makes the huge difference. So remember I said in the beginning, the first thing I look at the assessing the parenchyma. And you can see that's a normal liver parenchyma, that's normal, and that's cirrhotic. Now just look at this video. Without ultrasound scan, there is no way you can tell where the tumor is because everything looks exactly the same. So this is one of the patients with HCC. You can see the HCC, nice hypoechoic compared to the rest of the liver. I don't have it in this video, but you can identify exactly where it is, and then you can plan what kind of resection you're planning to do and about your margins. So that's the first thing. So you can assess the liver parenchyma. Then you can also characterize the liver lesion. So this is the typical colorectal metastasis. This is one of the patients I've operated where there were two tumors on the left-hand side. We were not sure whether both are colorectal metastases or not, but I could tell that one of them is not a colorectal met, it's a hemangioma, because that is a typical mucinous colorectal metastasis with the calcium in the middle, and you have the hypoechoic halo with mixed echogenicity in the middle. So I know that is a colorectal metastasis, but the hemangioma will look like a hyperechoic and bright, discrete lesions with no hypoechoic halo. Obviously, there are a few exceptions. So this patient is a 55-year-old lady with colorectal metastasis both on the right side, but two on the left side. One of them, I thought it's a hemangioma, so I didn't resect that. We did a mini ALPS. So that's a two-stage resection. And then we repeated the ultrasound scan, CT in 3 months' time. The hemangioma did not change. So if you know how to characterize the liver lesions, then it will be helpful. Obviously, you need to know this information beforehand because you don't want to diagnose them inside the operating theater. But you will come across patients where they have hemangiomas and tumors together. You will come across patients where there are multiple liver cysts and the tumors together. So for you, if you know how to differentiate those two, then you can obviously take out the right one and not the normal variations. Now, remember I mentioned about the tip of the tumor bug phenomena. Look at this, one of the patients I ended up operating and did a laparoscopic extended right hepatectomy. That is what you see it. But you may look at the ultrasound scan images, guys, okay? And that's the tumor. It's massive, much bigger than what it is. And also see how close it is to one of the portal vein branches. And there were actually more tumors And there you go, another tumor there. The same tumor, but it's much bigger. But there was one more here. So we ended up doing extended, there's another one here, extended right hepatectomy. Okay, so it's important to do that and decide what exactly you want to do. What about the type of operation you do? This is one of the patient, one of my colleague was going to operate because in our center we only two of us will do the hyalocholangiosis. This was a peripheral cholangio. Plan was to do a left hepatectomy, but when he did an intraop ultrasound scan, so that's the tumor. Okay, but see what is happening here. That is the portal vein. But look at the right and the left bile duct, hepatic duct. They are completely compressed, and the tumor is right at the confluence of the left, right and the left hepatic duct. So there is no way you can do a left hepatectomy without damaging the bile ducts to the right side and also getting a R0 resection. So we changed completely, plan from peripheral cholangio to hilar cholangio and did a much more extended resection. Look at this one. This patient was supposed to have a right hepatectomy for a hilar cholangio, but when intraoperatively, when we did the ultrasound scan, this is actually one of my colleagues' case, and see what's happening here. So see the filling defect? So that's in the left portal vein, and that's the right portal vein. Obviously, you must put the color on and you must look at the Doppler wave pattern. You can't tell otherwise whether it's a portal vein or not. So I always press the color button. You can see the yin-yang appearance already, and that's the filling defect. And see I'll show you a bit more. There you go. You can see clearly. Okay. So that's the right portal vein, and that's the left with the tumor and the yin-yang appearance. So straight away, it's an inoperable case. So that imagine if you operate on this patient without intraop ultrasound scan, it's a disaster. You would have a death either on the table or post-op. This is one of the case I helped in India during one of the teaching sessions. So the plan in this patient was to do a right hepatectomy in a cirrhotic liver, massive HCC. Everything was planned, and the scan was literally 24 hours old. And they asked me to do the intraoperative ultrasound scan after the workshop. I happened to be there. So I did the intraop ultrasound scan, and you can see what's happening. That's the tumor. That's the middle hepatic vein. That's the filling defect. Just to go back again. See that? That's the filling defect. And that's the middle hepatic vein. So not only the tumor is actually right on the middle hepatic vein, but also there's a thrombus in the tumor thrombus in the middle hepatic vein. So that was inoperable. It was unfortunate, but it was fortunate in one way because at least patient could survive and go and have some immunotherapy and chemotherapy. What about this one? So this is a young patient. I did a right hepatectomy in the past for colorectal metastasis. Came back with recurrence in segment 4, and the plan was to do just a wedge resection. This is just to show you how important it is to do the ultrasound scan in 2-3 different planes. Okay, so that's the MET right on the cut end of the liver. Easy to do it. So that's a typical colorectal metastasis with a halo around it. So the plan was to do a wedge resection. But then you repeat the ultrasound scan in a different plane. Remember, patient had a right hepatectomy. And that's the tumor. And that is the left hepatic artery, unfortunately. So there is no way you can get a R0. Forget about R1. You may be able to get R1, but there's a high risk of damage to the only artery that is going to the liver. So we didn't resect it. It was open and closed, and the patient went on to have more chemotherapy. So it absolutely made the difference to the patient and for us. And then obviously, if you want to mark the margins, whether it's a lap or robotic, you don't have the tactile feedback. And I've already mentioned, even if you have the tactile feedback, it won't be accurate. It'll be subjective. So we never do that. And we always do the ultrasound scan, and you mark it with the diathermy. And then if you place the probe where you marked it, you can see the post-acoustic shadow. That's the tumor here, and that's the margin marked with the diathermy. So we always do that. Now, remember I told you about the disaster I had where the stapler moved to the left side and narrowed the left portal vein after a laparoscopic right hepatectomy, and we ended up opening the patient in the middle of the night. So that's very stressful. So I have a bad habit of changing things if I'm not very happy because I want to enjoy what I do. Surgery is fun for me, so I always try and make sure that I minimize the human errors. So that I don't get a call in the middle of the night saying that something has gone wrong with the patient. So just to show that, since then I've changed my tack. So if I'm planning to do anything lap or open, so here the right hepatic artery is taken. This is a planned laparoscopic right hepatectomy. Now we do that robotically, but sometimes the robot is not available, so still we do lap as well. So what I have done is put a suture around the right portal vein, pulled it down, then drop the liver. And then I'm going to assess the flow to the remnant liver. So I'm pulling the right portal vein really nice and tight. So there's no flow to the right, and you can see the demarcation line here. But the most important thing I'm interested is the opposite liver. And I also do that before I staple it, and I also at the end of the operation. So I place the ultrasound probe on the left side, and you can see that's the ligamentum venosum there. That is the left portal vein, and you can see the nice yin-yang appearance. And then you use the Doppler, and you should see the positive or negative flat wave. Then I know that is the portal vein. And also you look at the artery as well. So that's the artery first. That's a triphasic arterial wave pattern. So I'm happy that the artery is intact to the left side, obviously. And then you go to the probe, to the portal vein, use the pulse wave pattern. Let's look at the, yeah, there you go. Okay, so that's the, I think that's a vein, or it's probably picking up both the vein and the artery. But I was happy that it's the left portal vein and the left hepatic artery were intact. Okay. What about ablation? So as I said, the ultrasound the radiologists come into theater and they do the ablation under our guidance. We help them to, because the radiologists are not used to the intraoperative ultrasound scan because the sensitivity is much higher. So we help them to place the probe. So that's the tumor, and one of the radiologists is basically placing the probe into the tumor to do the microwave ablation. And when that is the needle, and that's the tumor. And once you start the ablation, you can see what we call a sonication, because the water bubbles comes out. You can see that. So we know that the probe is active and it is doing what it should be doing. So what about its role in liver transplantation? You know, vascular complications are the dreaded complications of liver transplantation. So it's very important for you to make sure that your arterial anastomosis, portal venous anastomosis, and hepatic venous anastomosis is absolutely fine. It is not narrowed and there is no thrombus. And you better want to do that intraoperatively. Of course, you want to repeat that percutaneously post-op if there are any issues, but we want to do that, make sure that before you close the patient, you want to check all those three anastomoses are patent and there's no issue. So ultrasound scan will be of very, very, very useful. And for example, look at this one. So that's a normal anastomosis, that's IVC, and you have the hepatic venous anastomosis to the hepatic IVC. Its flow is absolutely fine. There's no narrowing, so you're happy, and there are no filling defects. And look at this one. So one thing you must remember, if you're using the artificial graft, you won't get any color signal because the ultrasound waves will not be able to get through the material, but you will have the color above and below the graft. And you can see that that is a hepatic venous pattern. That's nice yin-yang appearance with no filling defect. And this is hepatic arterial anastomosis, absolutely fine. There's no issues. But if you look at this one, and you can see the difference because there was a stenosis and you relieve the stenosis and the flow pattern gets better. And here you have the size discrepancy between the recipient portal vein and the graft portal vein, and you can see. But there's no issue. It's just that the velocity is different. As long as you're happy that there's no filling defect, you're absolutely fine. Here you can see a thrombus in the right hepatic vein. Obviously, once you identify, you can do something about it. What about the ultrasound scan in pancreatic surgery? So these are all the uses I use it for. So I use it for location of the pancreatic tumors, especially if it's a distal body and the tail tumors, and identify the resection margin. If there are multiple metastases, for example, if you're operating on a patient with multiple neuroendocrine tumors, you want to take all of them out, or you want to do a total pancreatectomy, or you may want to do a distal pancreatectomy, but you need to know exactly how many tumors are in the distal body and where the margins are going to be. You can also identify whether it's resectable or not. And also, I use it quite often to preserve or not to preserve the spleen, especially if it's a pre-malignant or benign tumors. And then if the vessels are not involved and there's no inflammation around the vessel, then you can preserve the spleen. You can also identify the nodes and take them out. And you can plan what type of resection you're planning to do in terms of the extent of the resection. This is one of the patients I've operated. Sorry, are we okay? I won't be long now, 2-3 minutes. So this is a patient with a massive hiatus hernia. The stomach and the colon was inside the chest, and the patient is supposed to have a lipoma. Now, if you're doing this laparoscopically, even if it's open, one is you don't know where the pancreas is. That's one. Two is even if you identify the pancreas, you don't know where the tumor is. So it's almost like blind leading the blind, and you don't want to spend so much of time not to know where it is. So I opened the lesser sac and I tried to find out where the tumor is. It's pretty impossible. I've also used the ICG again with not of much help, and then you place the ultrasound probe directly on the pancreas where you think is the pancreas, and you can see where the tumor is. That's the tumor. Okay. I haven't got the corresponding image. There you go. That's the ultrasound scan, and that's the ultrasound image. That is the tumor. So now I know exactly where it is, and I'll go and look there rather than dissecting entire body and the tail of the pancreas and looking completely blindly. And then, as I've also said about the resectability, that's a massive tumor, a neuroendocrine tumor of the head of the pancreas. And then that's the portal vein. So you know whether it is resectable or not. And if it's resectable, whether you need to take the vein with you or not. Okay, so that's the SMV, and that's the tumor. This is a low CBD tumor. Sometimes you won't be able to see or feel the tumor, but if you do the ultrasound scan, you can see the tumor exactly where it is. That is a stent, but that is a hypoechoic tumor. You can see the vascularity as well. So again, you can localize it exactly where it is and assess the resectability. This is an interesting patient with came in with a recurrent pancreatitis from a different hospital. That's the PD. Obstructed PD is massively dilated, and you can see the tumor. This is IPMB, by the way. It is coming from the lower end of the bile duct going into the pancreatic duct. And we ended up doing a Whipple's operation for this. What about in biliary surgery? What is the reason why we do the intraoperative imaging in biliary surgery? There are four reasons as far as I'm concerned. One is to identify the biliary anatomy, vascular anatomy, and also to prevent the bile duct injuries. And then if you want to, then you want to identify if you have done a bile duct injury. Then the third and the most important reason why I would do the intraoperative ultrasound scan is to identify the stones in the bile duct and plan the type of approach, whether you want to do a transcystic or transcholedochal. And then more and more often now I use it to assess the difficulty of the cholecystectomy as well, because ultrasound scan is very sensitive in telling you the planes and whether it's going to be a simple, straightforward cholecystectomy or not. Especially if you're thinking it's going to be difficult, it will be helpful because then you can preempt it, how difficult it is going to be. Now, what are the imaging options? So you have three imaging options for the intraoperative imaging. One is the old one, which is traditional, quite commonly done still, is intraoperative cholangiogram. Then intraoperative ultrasound scan, and the fancier one, the latest one, is intraoperative fluorescence cholangiography, which I have a lot of experience because I use it in liver surgery, but I stopped using for the biliary because it's not really of that help. I know some Japanese and Koreans and even a lot of Indian surgeons are using it, but it has got a lot of limitations. Okay, so if it's IOC, obviously it's time consuming. There's a risk of injury to the bile duct, and you won't be able to cannulate the bile duct all the time, cystic duct all the time. You need at least 10 to 15 minutes to set it up. You won't be able to repeat it. It's time consuming, and there's definite morbidity associated with it. What about the evidence? There is a clear evidence. I mean, look at this one. This is a massive meta-analysis. They've used 440,000 patients from 14 studies. And then they compared patients who had IOC versus who didn't have a IOC. Absolutely, there is no evidence to support that the IOC will prevent the bile duct injuries or detect the bile duct injuries much more than in patients without IOC. So that is evidence there. What about the ultrasound scan? Ultrasound scan is quick and safe. It can be repeated as many times as possible. It's non-invasive, no radiation. There are no contraindications. It will help you with the vascular anatomy, biliary anatomy. It will tell you where the stones are, how many are there, how big are they, what is the diameter of the cystic duct, what is the diameter of the bile duct. Then you can decide whether you want to do transcystic or transcholedochal. You can repeat it as many times as possible, and it's very quick. Literally, when I'm doing it, I literally take about 30 seconds once it is set it up. So average, it's setting up, it will take about a minute, and then to do it, it'll take about 30 seconds to a minute, and you can repeat it. So it's obviously it's a no-brainer really, but still, unfortunately, surgeons are still using IOC. God knows why. I stopped using it in 2014, and now I only time I use is if somebody calls me that they've done a bile duct injury. That's the time when I use the intraoperative cholangiogram. Otherwise, always intraoperative ultrasound scan. But obviously, it is subjective, and so there is a learning curve to it. Those are the limitations. Just to show you a video. So these are the comparison between the IOC, IOUS, and IFC. I'll just mention about intraoperative fluorescence cholangiography, and people use it to identify the bile duct anatomy so that they don't damage it. But actually, why do you need to look for bile duct? As long as you stay high and you develop the critical view of safety, only two things that are going to the gallbladder after you lift the gallbladder from the liver, you cannot damage the bile duct. Of course, it can still happen, but it's extremely rare if you stick to that. If you are running into trouble with that approach, then you go for the fundus first method. You come from the top to bottom. Or you open the gallbladder, the front wall, take the stones out, and then dissect it out around the Hartmann's pouch. That I've done that approach quite a few times. I don't do subtotal cholecystectomies, by the way. A lot of surgeons claim that it's for the safety. I think it's got a lot of morbidity. And you can do almost. The only time I've done subtotal where I've left the cystic duct stump is once in my life. That is in 14 years as a consultant. So I do for the other surgeons where they've done the subtotal cholecystectomy, you end up taking them back to theater. So I use ultrasound scan quite extensively to know where the cystic duct is, where the gallbladder, Hartmann's pouch is as well. If not, you open the patient, you come from the top to bottom, and you can do it, as I said, most of the time, 99% of the times, you can take the rest of the gallbladder. If not, you put a drain and come out and let somebody else fight on another day rather than doing a subtotal cholecystectomy, because this is not a life-threatening surgery, you need to do it. You can always come back and fight on a different date. So in terms of the fluorescence cholangiography, you got the timing has to be absolutely fine, and you need to get it before the surgery, at least half an hour, 40 minutes before. The liver will look green, so that can interfere with the bile duct anatomy. If you have any bleeding, you won't be able to see where the bile duct is because the blood will cover the bile duct and everything will look green. If you have a Merijie syndrome, everything is inflamed, you have no idea what is what. So it's not of that use. And also, if your bile duct injury is, let's say, 1 in 1,000 to 1,500 patients, that means that you have to do that many number of times to pick one biliary injury. I mean, it's absolutely no brain really why you would do that. So what are the indications for intraoperative ultrasound scan? In my view, this is my practice, so I use it. If it's a dilated bile duct, either an ultrasound scan or MRCP. If they have confirmed stones in the bile duct on preoperative imaging, if they have raised ALT, gamma GT, and bilirubin, don't use the alkaline phosphatase. It's very, very non-sensitive and non-specific. So I rely heavily on gamma GT and ALT and bilirubin. Acute pancreatitis because there is a risk of them having a bile duct stone. And as I said, if they have got confirmed stones on the preoperative imaging. Lastly, I'm just going to show a video of the biliary imaging. So I place the probe in the epigastric port, and the probe is directly placed on the bile duct. That's the cystic duct, that's the bile duct there. I press the color button. So if there's no color, I know that those are the cystic duct and the bile duct. That's the portal vein, and that's the lymph node, which is always there. And that's the stone. You can see that. That's the stone in the bile duct with the post-acoustic shadow. Again, that's the stone with acoustic shadowing. This is an unedited video, by the way. So it literally takes about 30 seconds. Okay. Again, multiple stones in the bile duct. That's the lower end. I think I'm going to stop there, guys. Thank you very much.
Thank you,
Hello.
Sumaya sir.
Yeah, go ahead, sir.
Yes, Avinash sir. Yeah, now you can.
Hello.
Hi, guys. Yeah. I think a lot of people talking at the same time.
Anand sir, go ahead.
Yes, some internet connection is issues there. Issues here. Avinash sir, now you can ask the questions. Avinash sir, I'm audible.
Yeah, I can hear you, Anand.
Yeah. Yes, sir. We are also using this intraoperative ultrasound. Every time we ask our radiologist or intervention radiologist to come in the theater, and they do the same for us. The difference, you are doing everything. With time, we will be competent enough. We'll do the intraoperative ultrasound with time.
Yeah,
Yeah.
I'm sure.
Yeah. Avinash, I want to ask something, sir.
So there is a question, Anand. Dr. Binaya Tim listener, she's asked, he or he, I'm not sure, asking
He, sir.
yeah, he
Hi.
is asking about role of ultrasound for segment-oriented liver surgery. So the answer is very simple. Ultrasound scan made a huge difference, and now we are doing more and more parenchymal sparing surgeries. We try and avoid doing major surgery. Without ultrasound scan, there is no way we would be able to do that. That is one. Two, ultrasound scan is very useful if you want to inject the ICG into the portal pedicle of the segment. You want to resect it, so you can do either negative or positive staining. So obviously, if you want to ligate the pedicle, then you inject it, so it will be negative staining because the segment which the ligated the blood supply will be negative. The rest of the liver will be positive. Or you can basically inject directly into the segmental vessels and you can have a positive staining. So absolutely, its ultrasound scan is the crucial. And actually, we got the kind of paper written up. We're going to publish it hopefully soon. So the ultrasound scan
आपने तो
makes a
बताया बात
difference.
में
Yes, sir. Yes, sir. No, sir. Some disturbance was there.
No, that's okay. So that
Yeah.
I hope that I answered that question. Yes, absolutely. There is a
Yes.
crucial role for ultrasound scan to play in segmental resections.
Yes, sir. What I learned when I went to Korea, when they are doing this subsegmental tumoral or tumor resection, they what they do, they put a ICG 1 day prior under ultrasound guidance, identification of the portal pedicle, and they put a ICG in this pedicle so
Yeah.
they can identify the tumor or the subsegment intraoperatively during the surgery.
Yeah. You can do that, Anand, at the same time. You don't need to do it 24 hours before. Obviously, they have the luxury, but you can do the robotic or ultrasound scan. You can identify the portal vein supplying the segment and you inject it. It's not easy to do that, but with practice, you can do that.
Yes, sir. Gradually, we are also learning the intraoperative ultrasound, like doing after the implantation. We ask our IR colleague or radiologist to do the intraoperative ultrasound for the vascular patency of the hepatic artery, but even the hepatic vein. And we are also gradually learning the how they do and how we can learn from them.
I mean, that is one of the aims of my life, to teach as many people as possible. That's why I'm doing all the workshops in India. So hopefully, with time, the surgeons would pick it up and do it for themselves. Then they don't need to call the radiologist. And also, I think I've given you the technique as well now. It's published, by the way. So, anybody can use that technique and learn into ultrasound scan.
Yes, sir. Please share the article if it's
Yeah, yeah,
possible
I will.
with me.
Yeah,
I will share the article in our group.
yeah,
For the our student will can be benefited with your article, sir, by reading the article.
absolutely.
Yes, sir.
Thank you.
Dr. Avinash, sir, do you want to say something? Dr. Avinash is our main coordinator of this online class because
Yeah,
he
he's
is
muted.
creating. Uh,
Hi, Avinash.
Most probably he is mostly something he is busy because he is creating the link and he is putting all the classes to our Gastro University, the
Oh,
link
I
over the
see.
YouTube. Yes, sir. And Dr. Hira, want to say something for the closing remark for the today's class?
Hello, good morning, sir, and really very excellent talk. Really very excellent, and you covered almost everything, like what we do interoperatively, and I think you're doing fantastic job. Hello.
Thank you. Thank you. Thank you.
Yeah, and right from the characterization of the lesion, the liver anatomy, and the liver abnormalities, and what a surgeon want, I think you covered everything, and really it's excellent talk, and I completely agree that intra ultrasound should be done by surgeons so that we don't need to go in and
Yeah.
was yeah.
Yeah.
So that is great, and it's great initiative, sir. And I really appreciate you took time and give classes. And you also told that you are doing some workshops, so that will help surgeons to do intro of ultrasounds.
Absolutely. Yeah.
Yeah, and thank you so much, sir, to spare time.
Thank you, everybody. I hope you had
Yeah,
a
yeah.
good session. Okay.
Have a
Bye
great,
bye.
yeah. Have a great day, sir.
Yes, sir. Thank you, sir.
Thank you.
Thank you,
Bye, Anand.
Somaya sir,
Yeah.
for accepting our request for the class, sir. And thank you for so sorry for disturbing early in the morning.
No, no, it's okay. It's my pleasure,
So
Anand.
we'll
Thank
be
you.
having
Anytime.
yes, sir. We'll be having more classes from your side, sir. We'll ask you
Please
for
do let me
the
know because obviously there's a lot more. So we do that. I do that for a NATCO center in Andhra and also EHPBA. So yeah, let me know the topics well in advance. Then I can absolutely happy to take part. Okay.
Oh, and whenever you have a time to come to India, just inform me. We can arrange something here in AIMS Rishikesh for your side, so we
Yeah.
can plan something for the for the our colleagues or the faculty colleagues for the which can be we can take benefit from your whenever you come to India, sir.
Okay. No problem, Anand. Thank you very much for the
Yes, sir.
offer. Okay. I'd
Yes.
love to do that, and I can at least visit Rishikesh as well at the same time.
Yes, sir. Yes, sir. Yes. Thank you, sir.
Thanks,
Thank
man.
you.
All
Okay,
right,
we
Anand.
are
Bye.
bye, sir. Bye. We are closing the
Bye.
session.